Hello, my name is Dr. Amir Panezai. Today I'm going to talk to you about hydrocephalus. What is it and what is the cause of it? What are the symptoms of it? How you will treat it? So hydro means water, cephalus means in the head, water in the head. That is the cerebrospinal fluid, which we call it CSF. Obstruction to the pathway of the CSF leads to increase the size of the head, and that's why it's called hydrocephalus. And we will just talk about little bit about CSF, how does it form, how it circulates in the brain. The cerebrospinal fluid, or CSF, is formed in the ventricles of the brain, mainly lateral ventricles and fourth ventricles. From there, it goes to the between the interventricular foramen from lateral ventricle to the third ventricle, from the third ventricle to aqueduct to the fourth ventricle, and lower down into the medulla through foramen Luschki and Magendie, and then spinal column and go to the blood and absorbed and arachnoid granulations. So that's the pathway. Any obstruction to this pathway will lead to the hydrocephalus. And there are types of hydrocephalus, we should discuss it. One is communicating hydrocephalus, one is non-communicating hydrocephalus. Communicating hydrocephalus, when there is no obstruction into the ventricle pathway of the CSF, and non-communicating hydrocephalus is when there is obstruction in the pathway below that. So there is a causes of it. Before causes, we will go to, it could be a congenital hydrocephalus or it could be acquired hydrocephalus. The main pathogenesis of hydrocephalus is absorption, formation and absorption. If there is more formation of the hydrocephalus and the absorption is less, that will lead to hydrocephalus. Like, since it formed from choroid plexus, like choroid plexus papilloma and choroid plexus carcinoma. And the next one is the absorption. So also in absorption, if there is a head injury, if there is an operation done, if there is a tumor removed, if it is a meningitis, that pathway will be blocked and will lead to the hydrocephalus. So it is the equilibrium between absorption, formation and absorption which lead to it. And then its types, as I told you, is communicating and non-communicating. And then the other one is type is tuberous sclerosis. That's hydrocephalus mainly. The cause is not known, but it's mainly in high BMI patient, more common in female, present with the headache and papilledema, with normal ventricles or enlarged ventricles. That are the four type hydrocephalus is the normal pressure hydrocephalus. This normal pressure hydrocephalus is mainly in old age, more than 60 years or 50, 55 years. The patient usually presents with the headache, incontinence of urine, and dementia. That is the main presentation of the normal hydrocephalus. congenital hydrocephalus starts in natal, prenatal, in infancy. The main cause is Dandy-Walker syndrome. That is a cystic dilatation of the fourth ventricle and hypoplasia of the cerebellum, which leads to hydrocephalus. And the second is Chiari malformation. Chiari malformation is the maldevelopment of the posterior fossa, which cannot accommodate the cerebellum due to small formation of the posterior fossa. When the brain gets bigger, it descends into the foramen magnum, and that's called Chiari malformation. It has got first 2-3 type of it. I will not go into the detail of this. And the acquired is anything from head injury, as I discussed it before, to meningitis, to tumor, any type of tumor to be removed, and also if it is a benign tumor, it can cause it pressure in the head. If it is malignant, operated after the patient death, that is the hydrocephalus. So the signs, symptoms of that, first in the children and then in adult. Children mainly before 2.5 years old, usually the head circumference gets bigger. The mother or the parents will understand that the head is getting bigger. And also there is a tension in the anterior fontanelle. And the mother will say that this is bulging. Especially those mothers will notice early when they had a previous baby that's normal to them. And then with the time, again, there will be scalp vein, visible vein on the head. We're taking a more long time. What will happen? Then the eye will sink in, which will show that it is pressure on the brainstem area, and then which is called sunset eyes. And also the bone will be thin by itself when you move it, because the bone is moved in different parts that may be depressed. While in adult, in the child, other child also complain of the irritability, feel sick, not being well, and vomiting, drowsiness. All these symptoms will be in the child. But those in adult or in late childhood, any cause of it, the symptoms will be headache, nausea, vomiting, irritable, poor concentration, not able to work, loss of sleep, and also urinary symptoms like I said before, and also dementia in old age, and nausea and vomiting, and so many other complaints they will have due to that. So all these signs, symptoms, then the investigation for those. For children, any patient, adult or children, a good history and examination is very important. History from the mother, from the birth, how was the birth, and from there onwards, any trauma, any history of head injury in the past, all those history to be taken in children. And then in adult, so with these signs, symptoms and examinations, especially children, the papilledema in 2 years' time. It is difficult to see, but in adult children or old children, there will be also swelling of the fundi, swelling of the eyes as well. And once these are done, these will need some investigations. Investigation, plain X-rays, not nowadays is a rule, but in some of the countries, when the CT scan is not available, they do take the plain X-ray of the skull. The skull will show large, thick, and copper-like hitting signs with that. That is one of the signs which is done. But while nowadays the CT scan is available everywhere, so the CT scan, apart from the normal blood, you take it as a routine investigation, is the main one. And sometimes you take in more detail in acquired hydrocephalus, the MRI as well. And also in normal pressure hydrocephalus, we do the LP to see the pressure of the LP, and also do the lumbar puncture. And then we may do the normal pressure hydrocephalus to note or to record the ICP through a probe into the, making a burr hole into the brain for 48 to 24 hours to see if in sleep or in waking, what is the ICP, how high it goes. So the normal, up to 25 is normal. Beyond that, we will be worried about the ICP monitor, ICP pressure. So when that diagnosis is being done and it is confirmed it is hydrocephalus. So we will come now to the treatment part of it. Treatment will again we divide into 3 phases: no treatment, medical treatment, and surgical treatment. It is mainly the surgical treatment which is the treatment, but sometimes you may say that no treatment. The reason for that, some of the patient, early or late children or in adult, they have hydrocephalus, but they don't have any signs and symptoms of hydrocephalus like nausea, vomiting, headache, lethargy, restlessness. So those are called arrested hydrocephalus. They should be watched, closely observed in 3 months' time, 6 or yearly, just to see how they do, and to be told to the patient if he had any symptoms to attend the hospitals. That is the or what you call arrested hydrocephalus. The second is the medical treatment. There is nothing too much about it. They just give some diuretics to increase the absorption of the CSF. It may help, it may not help, but that just, to me, it's buying a time. The main treatment is the surgical treatment. So we will come to the surgical treatment. Surgical treatments are actually diverting the blood, the CSF from the ventricles, from the obstructed area. So they make a burr hole into the back of the head, just behind the hair. Sometimes they do burr hole, what we call it, frontal burr hole, just in the front of the head. And then the ventricular catheter, small tube, which we call it a ventricular catheter, that is passed into the head, into the ventricles, maybe the anterior part of the ventricle or posterior part of the ventricle, maybe on the right side, maybe on the left side. And that is coming down under the skin into the abdomen. that is called ventriculoperitoneal shunt. Nowadays, there are so many types of VP shunt which can be monitored on the bulb and the skin as well. That is called ventriculoperitoneal shunt from ventricle to the peritoneum. The second is ventriculoatrial shunt from the heart, right side of the heart, superior vena cava, and from the back or front of the head comes to the upper part of the right side of the heart, superior vena cava. The catheter will put there. This operation used to be done a lot in the past, but nowadays it is only necessary to do if there is some complication, contraindication is putting in the abdomen, like pregnant women, many surgeries on the abdomen or any abdominal pathology which cannot be, catheter cannot be put, that could be done in the atrial. And then if that is not possible, ventriculoatrial shunt, abdomen is not possible, the third part is the ventriculopleural shunt. It is just into the chest, into the pleura, from the ventricle, put the catheter there, and the CSF will be absorbed. Modern ones, sometimes they do ventriculoureteric or ureter shunt. From the ventricle, they put in the ventricle to the ventricle. So the CSF goes to the bladder and from there out. So these are different type of treatment. Sometimes there is a lumbar peritoneal drain, the lumbar peritoneal shunt. That could be also one type of treatment, especially in normal pressure hydrocephalus. And then sometimes you do the surgery for hydrocephalus, maybe in emergency. These are all which I discuss it. These are the cold cases to be done. But in emergency, sometimes the patient presented in acute hydrocephalus, like tumor in the third ventricle or aqueduct stenosis. So the only thing you have to do in an emergency to put a burr hole and just diverted the CSF flow outside. Or in emergency, the patient has hydrocephalus, but he has an infection. In infection, you cannot put the peritoneal or atrial or ureteric part into the tummy because the infection will spread. You have bring it as the outside till the infection is cleared, and then into convert whatever is needed to be converted. Okay, now next I'll come to the complications of the surgery especially. So like any surgery, this shunt also got some complications. Complication, if you divide into two, on the ventricular end and on the abdominal end, or wherever you want to put it. So on the ventricular end, the complication may be bleeding, small hematoma, or big hematoma, which may need surgery. That's not very common, but it can happen. Also, in lower end, especially peritoneum, may be injured to the bowel. Any bowel could be perforated. And also in pleura, going into the lungs, intrapleural, they can happen. And moreover, the infection of the ventricular end or abdominal end Once the infection happens, the patient may go septic with meningitis. In that case, what happened, the shunt should come out to be changed into EVD, means external ventricular drainage, till this infection is cleared. And then I said before, it will put it back. So that was the short lecture about hydrocephalus. I hope you will get some benefit from it. Thank you very much for listening. Thank you. Goodbye.